General orthopedists may do things like foot and ankle, may do things like hip, but they don't do certain things, right? Because some things are specialized. That's not what I mean by general orthopedics in this lecture, okay? What I mean by general orthopedics in this lecture is giving you a dip into the deep end, if you will, okay? Giving you a sense of like what we're going to get into and just some general concepts of what orthopedics is. Because would you agree that orthopedics, we'll see, we're testing, right? Would you agree that orthopedics is its own language? The answer is yes, it is, okay? So again, we need to get to talking the same language. That way when we discuss things and we speed up a little bit, you guys are like, wait, whoa, what are we talking about now? I want you guys to start thinking about things in certain terms, meaning in orthopedic terms, okay? Good to go? And then obviously spine is spine, right? So everybody knows that lower back pain, all that stuff is very common presenting symptoms in the patients that we take care of in the military, correct? Whether you know it or not, or whether you believe it or not, 40 to 60, upwards of 70, 80% of the patients you see on a daily basis, especially if you're working at DAS level or at the primary care level, are going to present with musculoskeletal complaints. Okay? So whether you believe it or not, you'll come back to orthopedics at some point and learn your physical exams out of necessity. Well, we'll try not to do it that way. We'll try to learn them out of priority, right? We want to prioritize these things. So that's the stuff we're going to get into. Unfortunately, this block, right, this block, you guys don't get neuro until the end, a few weeks away, right? And that's unfortunate. So I'll try to spend more time talking about the neuro stuff, okay? Again, I'm a physiologist, I get into it, but we have to keep moving, okay? So objectives, we're going to talk about principles of musculoskeletal evaluation. Okay, we're going to talk about fracture evaluation and management principles. So what is a fracture? How do we manage things in general? Operative versus non-operative management principles. Corticosteroids and NSAIDs, right? Non-steroidal anti-inflammatories. And arthritis, and you see how it's written there, arthritis, osteoarthritis, right? Because all arthritis is not osteoarthritis. We're going to get into rheumatoid arthritis, different arthritis later, so it's important for you guys to start differentiating these, okay? Good to go? Okay. So getting right into it, patients presenting with MSK problems may report pain, stiffness, deformity, and weakness, okay? Now, the one thing I want you guys to start thinking about when it comes to doing, everybody's like, well, the OSCEs, right? Is there an MSK case in the OSCEs? Yeah, there is, okay? Is that every patient you encounter, you're going to ask them these questions. Because does ortho also go with neuro? Very commonly, right? In fact, yes. The answer is yes. Okay, so again, that gets to that weakness, okay? So if a patient can't do something versus it hurts to do something, those could be indicators of different pathology. Good to go? Okay. And I get a lot of phone calls, people saying, hey, this patient has pain, I can't get him to do this. What do you think I'm going to do when I come down to clinic to see that patient? I'm going to get him to do that, right? So the question becomes, is it just pain limited, or is it actually there's some kind of neurologic component to it versus some kind of, like say a rotator cuff tear, right? And there's pathology there that they cannot do it. Good to go? And deformity obviously gets to fractures, okay? So we'll start talking about those in those terms. Okay, so history-wise, you guys have your OPQRST, correct? Okay, this is a little bit of a different breakdown because in orthopedics, we want to know if it hurts, this says aggravators and levers. If it hurts, what makes it better? What makes it worse? Okay, so really in orthopedics, in musculoskeletal evaluation, you want the patient to tell you a story. Okay, make sense? You want them to tell you a story. You want them to tell you, hey, I was out running, so that was the onset, right? 4 hours ago, okay? And all of a sudden, my right knee started hurting. We're going right down the list. It's been hurting ever since then, okay? And it's worse when I try to walk quickly, and it's better when I rest, okay? Going right down this list, right? Character of it. I describe it as a sharp, dull pain to the anterior medial aspect of my right knee. Okay, and it is a 4 when I'm resting and a 7 when I'm up walking quickly, like I said. Good to go? So we've gone right down that list. okay? And then what's the last thing there? It says temporal factors. What is that? What are temporal factors? Things around, specifically around the actual complaint that the patient has, okay? For example, temporal factors could be related to time and or space. So meaning if a patient has a history of being a parachutist, right, they may report that they only have pain when they're doing certain activities with jumping. Okay, so temporal factors become important. So do you think that when it comes to MSK complaints, you might ask the patient, what do you do for a living? What is your MOS? What is your AFSC? What is your rate? What is your, I think I've covered everything, you know, what do you do, okay? Right? And what specifically do you do in that field? And what does a typical day look like? Okay, so you might ask those questions. Do you think you should ask those questions? Yes. Because do you think that if you see somebody for knee pain, you tell them to stop doing certain things, and they're an infantry soldier, and they go back to their platoon sergeant, and they tell them, hey, they told me I can't run. Where's your paperwork? Right? So you just let that patient go. You think they're coming back? They always come back. Okay? All right. So sometimes they're sent back by their first sergeant. Okay? So we'll get into that. So physical exam components. So inspection, right? So you're looking, right? What do I see? What do I observe? Okay? Right? Then you get into what? Palpation. Okay? So palpation again of those bony landmarks, those anatomical locations. Okay? Pertinent to the complaint. Range of motion. Okay? Do you have active and passive range of motion? You do. We'll get into that. Okay? We're also going to get into what is normal range of motion. That's not just something you document. You actually document the degrees of motion. And that's what makes it normal or abnormal. Good to go? Okay? Manual muscle testing. So that's at 0 out of 5 strength, right? We all know that 0 means no activity, right? No recruitment. Right? And then 5 means full strength compared to
The other side.
the contralateral side, right? Okay. Sensory evaluation, and they feel things, right? And what distribution can they not feel things? We'll get into that again when we talk about some nerve stuff, but also when we talk about extremity conditions as well. What's in red there? Special testing, right? So special testing is something we're going to get into very specifically because special testing, again, is going to become paramount to your knowledge in orthopedics, okay? And that's going to be that, you know, if we're talking about knee complaints, you're going to do X, Y, Z special tests, okay? Are we going to teach you all special tests out there? Now, again, I cannot do that in 7 periods of instruction, and I cannot do that with 2 to 3 labs, okay? But we'll teach you the ones we think are important, at least to start your journey in phase 2. Are you going to learn different special tests in phase 2? Yes. What you're not going to do is you're not going to say things like, we didn't learn this. Do you think your preceptor gives a, do you think they care that you didn't learn it? No, right? So again, you will learn more stuff, act accordingly, okay? So principles of fractures, okay? So evaluating fractures is just as important as treating them. Because do you think if you don't properly evaluate a fracture that you may improperly treat them? Yes. Okay, that's very common that we see. Okay? Orthopedic surgery exists for a reason, but again, you should know the basics. Okay? So I'm not going to read this to you. You guys already had discussion about what fractures are, right? But it's important to be able to characterize a fracture because again, the ability to properly characterize and put it into a category, if you will, is important for management. Good to go? Okay? And selecting a proper imaging modality is essential. We're going to get into it. Every time we talk about a certain condition, I'll tell you what imaging is relevant. Okay? You guys will start picking those apart. You're like, oh, for this I get an MRI for sure, because, et cetera, ... We'll get into that. Okay? All right, so x-rays, initial, right? So first time seeing a patient, first time presenting with a complaint. Is that in red? It is. Do you think in orthopedics, this is a joke, right? Some of you guys know this. Orthopedics can't see the patient without an x-ray. Well, like I just told you, if you are not able to properly categorize an injury pattern, then you may not properly treat it. So yes, we get x-rays. you guys should assume that you get x-rays for everything as the initial step, okay? So when we talk about a test question, if it tells you x-rays were done, it gives you an x-ray finding in the test question, in the stem of the question, and it says what is the next best appropriate management, and there's another imaging study there. Do you think that's what we're asking? Yes. Okay, so would you choose x-ray as an answer choice at that point? No, it's asking you what the next best step is, okay? PANCE does that too, by the way. I just took my PANRE, right, for the third time. I've been doing this too long. So PANRE asked questions, when I took it, asked questions just like that. It gave me a study, and it said, what is the best next imaging? I'm like, I know what this is, okay? In general, broad strokes, MRIs are used for confirming diagnoses, okay, and for surgical planning. I know you guys laugh and say, well, orthopedics gets an MRI for everything, right? But for us, we think about it in terms of making a treatment decision that may be different than just having plain films, radiographs, same thing, right? And also for screening for surgical planning, okay? So we want to nail it down and understand what is the pathology that we're dealing with here, okay? Good to go? So don't just order MRIs for everything, okay? X-rays come first. Soft tissue evaluation, you guys know MRIs are good for that. Spine, obviously if you're talking about neurological impingement, neurological encroachment, you want to look for evidence of that on an MRI, correct? Okay, and the last one there is what? May need sedation for pediatric patients. So do you think that if you're the kind of provider that just orders MRIs for everything, that you might hit a speed bump when you talk about peds? Yes, because you're making a big push, a big move to get an MRI in a kid, okay? So it has to be something that's of clinical value, okay? CT, again, surgical planning, right? Well, more so we talk about with intra-articular fractures. What are intra-articular fractures? Fractures and articulations, correct? So joints, right? So we get a lot of CTs for that, okay? Why? Because it changes the management. Trauma, stable trauma. You guys will get into that concept in senior year. Some of you guys already know this, but you don't send someone to the CT machine to die, right? You make sure they're stable first. You take care of all the soft, squishy things that aren't working right. Give them some fluids, then you send them. Okay, so again, when they're ready, when they're stable. And again, for CTs, do you think they're gonna, if it's a pediatric patient, you're gonna need sedation? Yes, you will, right? And also, by the way, for people that are claustrophobic, potentially as well. Okay, good to go? Fractures, I don't expect you to, I'm not gonna read all this to you. This is just a general overview. You guys will talk more about fractures in block 4. Okay, you're talking about specific fracture patterns, specific fracture treatment and management. Again, this is just meant to give you an overview. I encourage you to look at this. If you don't know the difference between a transverse fracture and an oblique fracture, for example, this is your primer, if you will. Okay? So take a look at this. I added this slide just to give you kind of an overview. Okay? But this is, for the purposes of this block, this is not tested. Operative versus non-operative, you're going to hear me say this a lot. Non-operative management is just that, meaning there's no surgical involvement, okay? And things like NSAID, RICE, rest, ice, compression, elevation, right? Certain kinds of like knee sleeves, for example, okay? What else? Activity modification of the profile, OT or physical therapy, occupational physical therapy, braces again, walking aids, that could be anything from a crutch to a cane, okay? And then corticosteroid injections, that's still not operative, correct? Okay, corticosteroid injections, we'll teach you guys some conditions you want to stay away from and some general principles, but just to introduce it, avoid tendons, okay? If you inject into a tendon, do you think you're going to weaken that tendon? Yes, then you got a tendon rupture. You got a whole other set of issues. Don't be that person, okay? We'll talk about that more. Operative management, anything with general anesthesia, most procedures with regional anesthesia. So what is it for that? So an operative procedure, when I go into the emergency room responding on a page about a patient that, I don't get paid anymore, but going to see a patient that has some kind of a condition that requires surgical evaluation to potentially go to the OR, do you think we might do certain things at bedside then that are still considered surgical procedures? We do. We do things like tendon repairs, open hand tendon repairs, okay? Make sense? So again, don't get locked into the fact that it has to be in the operating room, okay? Still an operative procedure if it's done in certain conditions. Anything with instrumentation, what's the difference between an instrument and an instrumentation? Yes. Yeah, exactly. We'll talk about X-Fix. So in case you guys didn't hear, what he says that you're placing it in the body, like an X-Fix, for example. Okay? Is that what you said? Yeah. I heard some of what he said. But most of it was right. So, but instrumentation is putting things in the body that weren't there before. Okay? So if you're given a case on a test question that it tells you plates and screws were used, was that a surgical procedure? Yes. Okay? All right. Good. And all open fractures necessitate surgical consideration. You guys will get to know that, okay? An open fracture is surgery until otherwise proven, and it's surgery, period, okay? Meaning you need to refer it, and not routinely, but page somebody, call somebody, okay? So I will tell you this, people get confused sometimes, especially at the primary care level, because they think operative versus non-operative is literally just that. Non-operative is all me, meaning the primary care PA, primary care provider, and then operative is all surgery, okay? That's not necessarily the case. Do you think if you refer a patient to me that has a labral tear, that we may actually initiate non-operative management? Yes, until it becomes clear that they need surgery. So non-operative management can be done at the surgical specialist level as well, until potentially surgical management is undertaken. Everybody understand that? And that's something I clarified last semester. Because people thought to themselves, well, if ortho's seeing it's all surgical management, well, I will tell you they're being managed by surgeons, by surgical PAs, but it may still be non-operative management. Good to go? Because when they fail, what's the second to last one there? When they fail on non-operative treatment management, do you think then we counsel them on surgical planning? Yes, especially for routine cases. Okay? That's when we get to the sexy stuff. So when we talk about fractures, surgical management, you have open and you have closed treatment. It's just literally what it sounds like. Closed treatment, you can put a little poke hole, right? That's what that picture on the bottom left is showing you there. And you can do it as a closed treatment. You're like, but didn't you break the skin? Yes. But again, it's not a major open approach. Would you agree that the one on the left is a major open approach? It is, right? So, in fact, that bottom left picture is called CRPP, closed reduction percutaneous pinning. It's still called closed, because even though you put a poke hole just to be able to fire those pins in there. You see that? Those pins there? Okay, to try to reduce that fracture and to keep it in a certain alignment. And then if you're not able to, for some reason, you're not able to maintain that reduction, or you have a poor outcome, for whatever reason, right? We'll talk about that. Then could you convert to that top right, excuse me, I know my odds are right. Top right, and you can do an open procedure? Yes, then you put more extensive hardware in there. You guys do see the more extensive hardware on the right side compared to the left side, correct? All right, so that's something I want you guys to understand. I'm going to pause and allow you to ask questions now. No? Okay. Am I going to be getting into specific surgeries? No. Am I going to go through broad strokes of certain surgeries? Yes. Because as primary care, you need to know what you're referring your patients for, okay, potentially. Okay? Do you think patients sometimes come see me? I talk to them about a potential surgery, then they come back and they see you. And they say, hey, Davilos told me about this surgery. What do you think? You're like, I don't know. He's a surgical guy. Right? I don't know. You can get away with that sometimes. But you got to know some general things. Okay? And I will not ask you techniques, and I will not ask you approaches. That is something I removed from this course completely. If you were a fellow, I didn't mention I was a fellowship director too. Right? So I love to tear people apart. But do you think that that's fair to ask you guys? No. What kind of decision would you do for this person? That's not, you don't need to know that kind of stuff. Right? That's too deep in the weeds. Okay? So if you see me get excited about it, just politely tell me, hey, sir, you're doing it again. You're going off on a tangent. I love the surgery stuff. Okay? I love it, but again, I've learned to pull it back, okay? And to keep it to what the beginning of this course is, okay? Good to go. All right, so getting to what the gentleman said over there, what's your last name? Mitchell. All right, what Mr. Mitchell said, internal fixation versus external fixation. Which is which, and what's the other? So internal fixation is literally what you see there. There's an internal rod, screws, plates, pins that are inside the body that were not there prior to what we did. Okay? An external fixation is what you see on the right there. That is, again, you make small poke holes potentially, but you put devices in place to try to take the fracture out to length and keep it stable until maybe either they heal it or you have to move on to do some kind of internal procedure. Everybody understands the difference between the two yet? All right, well, let me ask you a question. So do you think sometimes you can go from external fixation, because I told you that's temporary, right? Correct? To an internal fixation? Yes, and the purpose of that, again, external fixation is meant to be a temporary means of stabilizing a fracture, to either put it in a more anatomical position, take it out to length, for example, put it out to the length it's supposed to be at, sort of, or to prevent further injury, okay? And then, so that is relative stabilization, and then we move on to internal fixation if indicated to give them definitive fixation. Make sense? Any questions about that? I simplified that, but if you guys still have questions about that, please ask it as we progress, all right? All right, NSAIDs, you guys already know about the topic of NSAIDs. They can have some GI upset, right? But we use it to treat conditions in orthopedics like arthritis, bursitis, etc., tendonitis, okay? Can they have side effects? Sure. We do weigh that against the patient, right? So you want to make sure that you understand, are you doing it for analgesia versus antipyretic effects? What does antipyretic mean? Anti-fever. We don't really give in orthopedics, we don't try to necessarily bring the fever down. We try to figure out what's causing it, right? We're looking for infection, right? So, but in the case of orthopedics, we tend to focus more on the analgesic side of it. And we'll talk about that with specific conditions, okay? You need to know the adverse outcomes and side effects, things like dyspepsia. If they have risk factors like gastric ulcers and bleeding, risk of heart attack or stroke, okay? That has changed since I've been a PA. We used to say, well, if we get these NSAIDs, are better. Now the thought is, all NSAIDs are bad, but if you really have to, this one may be the least of the worst. Okay, but you need to know those things that we talked about before as far as the history and physical to know what the patient can tolerate or what you should be using. Hepatotoxicity, that is what? Your liver, right? So if you give too much of an NSAID, can you bad the liver? Absolutely, 100%. Okay, so you don't want to make bad worse. Okay? There are certain patients that can't take NSAIDs. And we'll talk about, especially when we talk about like rheumatoid arthritis, some things that we use outside of NSAIDs. Okay? Let's take a break. Come back 5 after.
Yeah, you're the one crashes in there. Yeah.
I have a question about it. I've never heard of it. Okay.
Yeah, we're not old.
Yeah, I meant to say it to them.
You have family, you run through one spice.
So I can text them. I did have a picture on it, so check the picture. As you know, which one's where. I put like I mean, you're here.
Is that a good one?
I don't have to move it.
Appreciate it.
I can't find ODO files. Yeah, like it's not.
I'll tell you later. I've never heard of that. Stopping there. The problem is you're looking for things. So because then you understand why you still
But then they have like there's a phase where you have
Right, I ate way too little break.
I'm ready. Here's my European injection. That makes it a little less nervous about that thing.
I like the way we do it, so we're like, we're in the Air Force. It's like A plus is one. Majority of it, and so I'll take that's all. Like it's something so
Yeah, exactly. I'm giving my max.
Bucky's Cook?
No, it's just a sticker.
Oh, you're supposed to just slap it on there.
You see, pull that a couple 10 miles per
We're talking about your
Yeah, but yeah, mine was 140. Like that's high up there. I was at 50.
Depends, like,
Mine like 4.
the hardest thing is
I mean, yeah, it's like, oh yeah. Yeah, and then we got
it's good. It's good because there, it's not going to ski. But it sucks because it's very hard. Like in the first season, like it didn't come so like overall it's a lot of great fun. But not really
I spend most of the time with the kids. We don't do lunch. Just went to Seattle. It's no pot. Yeah.
Sunday morning. I know.
Get stuff. I wanted to buy a home. And that's what he wanted.
Louis Vuitton.
Orange glad I didn't say
I just tell
banana.
him what I want.
Me, Megan, and Dakota. Huh? Me, Megan, and Dakota. What's that mean? Oops.
I save a lot of things like they're on Instagram. We're still like they're still like
Where's that?
I get distracted.
I thought you sent it out. He is going to. See, I was really thinking. I couldn't find you. I put Steve.
Not like legit.
Great. It's my.
That's how we're.
Alright. That's right. So always yes. The answer is always ready. Okay. Don't get ready, you stay ready. Alright, so this is, I was able to finally bring it up, but on the syllabus, I think it's important for you guys to see those resources, okay? What do we use a lot in the orthopedic level, right? When I say orthopedics, do you think I mean orthopedic surgery? I did. Because people think to themselves, wow, I'm an on-off management guy. I did that for 2 years. But more so what I do when I take calls, I'm looking for surgery, right? I'm looking for reasons to take the person to an operating room. But if you go to look at these topics here, you see ortho bullets on there. Has anybody used ORTHO bullets yet? No? Okay. I caution you, because I do recommend this as a resource, especially when you're in clinical practice. A lot of times when I get consults from PCMs, I will take them through ORTHO bullets. I will take them to that, I will send them a link if they're nice enough. Right? They don't make me angry. I will send them a link and I'll say, hey, look at this resource in your time. I'll answer the question, we'll manage the patient. But then it's a way to look at it and get some better understanding, and also talks about management, correct? And that's important stuff. You guys are going to learn at some point again that you have 20 minutes to make a clinical decision. Oh, and by the way, write your note, right? So the more efficient you become, the better you are. Okay? The reason I bring this up with the ORTHO bullets, though, and with any topic, right, any resource you may use, don't go too far to the right and too far to the left. Okay? What am I going to test you on? I told you I was going to be fair, correct? I'm going to test you on the material that's presented in the textbook, whether I agree with it in some respects or disagree with it, and I'm going to test you on what's on the slide deck. Okay? But if you go out there to the World Wide Web, and you find some resource from some study that was done in India, and you tell me, nope, they say this is the thing, and I tell you, page 378, paragraph 4, line 7, word 3, what does it say in the textbook? Who do you think wins in that case? The textbook, not me, the textbook, because that's what's important as far as the context of what we're learning. Okay? Good to go? Brutal, huh? Any questions about that? Still no questions? Usually get a lot of questions on the Thursday before the test. Okay, so we talked about that, we're good. Any questions about NSAIDs, the difference between corticosteroids and NSAIDs? That's going to become important as far as the treatment, right? Okay. We'll go through it, don't worry. So when we talk about corticosteroids, again, specifically, articular conditions, we do use a lot. We do use it in like osteoarthritis, inflammatory arthritis. What's the difference between osteoarthritis and inflammatory arthritis? You don't know because I haven't taught you. Okay, so I'll answer it. So osteoarthritis is literally inflammation of the joint due to bone destruction / cartilage destruction, which is a degenerative condition. Inflammatory arthritis, which you guys probably equate more so with rheumatoid arthritis, correct? Is a condition where your body hates you. You are trying to eat you. There's an inflammatory process occurring from a systemic disease pathology that is destroying your joints. Good to go? Can you have inflammation in osteoarthritis? Yes, very commonly you do. But by definition, it is not an inflammatory condition, right? Compared to rheumatoid arthritis. Don't worry, we'll hit that again. Because again, when you guys go through some reading, you'd be like, wait, they classify arthritis based on inflammatory versus non-inflammatory. And osteoarthritis is actually in the non-inflammatories, but there's inflammation. Inflammation is a secondary symptom, not a cause. Is that a better way of explaining it? Okay, good to go? I will continue to clarify. Okay? Oops. So we use it for extra-articular conditions, a lot more for like overuse type syndromes, okay? Bursitis, tendonitis, and for certain neurologic conditions. We'll get into that more so. Okay, but again, I told you to avoid injecting directly into a tendon, correct? Okay, so again, this is not talking about injecting into tendons, although it does say tendonitis, right? Well, you inject around the tendon, not into the tendon. Understand the difference? Okay. So do they cure anything? No. Again, I told you inflammation is a symptom, correct? They can cause pain. So therefore, it's meant to manage some of that. Okay? So when we talk about adverse outcomes, what does iatrogenic mean? Means you caused it, right? Potentially. Okay. Makes sense? Okay, so you don't want to be that person. So skin discoloration, it could be lightening of the skin. Okay. Fat atrophy, right? If you inject directly into a fat pad, it can cause the fat pad to atrophy. Okay. Does your knee have a fat pad at the anterior aspect of your knee? It does. So if you don't inject directly into the joint, yet you inject into that fat pad, can you have fat pad atrophy? That's not good. Ain't true. Okay? Tendon rupture, we talked about that too much. Chondrotoxic, what does chondro mean? Cartilage, what does toxic mean? Duh. bad things, right? So there is some studies that say that if you inject corticosteroids into young people especially that have normal healthy cartilage, it can actually cause the beginning of wear down of cartilage. And in that respect as well, if you have people that have advanced, right, osteoarthritis, and they have significant cartilage wear, can you cause it to wear the cartilage even more? Yes. So again, you have to be cognizant of that. And when we talk about giving injections of any kind, you guys know that you talk about risks, benefits, and alternatives with the patients, correct? And you get a consent form before you do an injection, correct? So you counsel them on all of these adverse outcomes that are potentially possible, okay? Hopefully you're not counseling them on the iatrogenic one. That just means you're not doing things right, necessarily. So. But the other things can occur even if you do the injection correctly. Make sense? Okay. So what is a splint versus a cast? You guys get splinting, not casting. We're not set up for that. You'll do casting in phase 2. But you guys will do a splint lab in block 4 of my course. Okay? So splinting, basically, bottom line is, right? Splinting is what? Non-circumferential, meaning that the splint doesn't go all the way around. You can see where the splint material is here, correct? It's not going all the way around. Right there, right there. Okay? It is removable, right? And a lot of times it's meant for short-term application and management of certain orthopedic conditions. Okay? Temporary until surgery or placed after surgery. Okay? And in contrast to a cast, which is circumferential, right? And why is it important to understand the difference between circumferential and non-circumferential? Just swelling. Okay? You guys read well. Good. But it's important for you guys to understand that concept too. If you put somebody into a cast and they should have gone to a splint because they came and yeah, they have a fracture, right? We need to manage that fracture. Or you put them in a cast instead of a splint, and now they're complaining about numbness in their fingers. Do you think that's because of the swelling that has occurred? Yes. So then you have to take a saw, a bone saw, right? And you have to cut the cast and put slits in it and allow it to expand. Does it become a splint then? It does, because it's no longer fully circumferential. Make sense? Okay, good. So don't put a cast on somebody that needs a splint, and vice versa. Okay? You can leave a cast on for days to weeks. Okay, and the one thing to understand about casts too is they can cause skin breakdown. More so. Yes, sir.
Sir, how would you know to automatically cast versus do a splint if you just expect swelling anyways? Is it just how they're presenting, or?
We'll go through that with specific conditions. So what his question is, how would you know to put a splint on versus a cast? So again, we'll go through that with certain conditions, right? But I'm not going to ask you about reductions and management of certain fracture patterns necessarily, right? But it's important for you to understand that if the question that you're being asked, say on a test, right, say PANS, right, is leading you down the path that maybe you put a cast on, you should have put a splint on, right? What are your next appropriate steps? And it's to relieve that pressure however necessary. Make sense? So in terms of like what specifically you would do a fracture, specifically you would put it into a cast, I will tell you that do we sometimes put people into a cast and then do a reduction? Yes, so all we're saying there, and we'll get into it again with specific pathology, is that you basically put a cast on while it's still wet. Someone like me, or maybe you, does a little push, as we call it. Sometimes it's not just a little push. It's awesomeness, right? You're hearing things pop, you're hearing things grinded, right? But you put it into what we call a more anatomic position, and then you continue to watch it heal. You take x-rays in a cast. And if you need to make changes, you take the cast off, you make those changes, right? And then you continue casting. Does that make sense? But splinting, a lot of times, we put more so in like, if you see some of you guys are ER guys, right? You won't get better yourself yet. You will eventually. But you guys are ER guys. So usually, when you put a cast on in the emergency room, no, you put a splint on, right? Until you refer them to see someone like me. Okay? So splinting, again, is a lot of times used for a temporary stabilization of the fracture. So it's not just flattening the limb, if you will. Okay, those bone ends are grinding, ripping into nerves, ripping into other things, and causing more damage. Make sense? But you didn't necessarily do a reduction. You didn't make things different. you just put them into a splint to temporarily stabilize the fracture bed. Did I answer your question at some point? Yes. Okay, that's a really good question. I say that because there may or may not be a question, right, on your exam coming up. What day is your exam?
23rd.
Okay, somebody knows. He's eager. He's ready. All right, so maybe there's a question on there that keeps it simple, right? So don't overthink it, is what I'm saying. I'm not going to ask you what reduction would you do for this fracture pattern. Okay, is that better? Okay, good question. All right, osteoarthritis. Okay, getting into osteoarthritis, it is what? Progressive, irreversible condition involving the loss of articular cartilage that sometimes leads to joint pain, right? Oftentimes, and it can lead to what? Deformity. Okay, if somebody has a breakdown of their joint significant enough, say to the knees, do you think they're going to walk weird? Right? Maybe they have varus angulation. Maybe they have valgus angulation. All right, we'll get into what those two things mean. But principally in weight-bearing joints of lower extremities and spine, that's usually when we talk about osteoarthritis. But can you have osteoarthritis of the wrist? Yes. Can you have osteoarthritis of your thumb? Yes. Can you have osteoarthritis of your shoulder? That's a large joint, right? All right, so we'll talk about those specifically, okay? Ding, ding, ding. Leading cause of impaired mobility in the elderly. Do you think a question like that, or let's say a concept like that, is something pants might zero in on? They love these kind of questions. Okay, so again, whenever possible, I will try to prepare you for pants as well. Okay, I'm not teaching you the test. I'm just teaching you to be better. Okay. Primary, right, and versus secondary. So there's two different kinds. Primary, the way you can think about primary is that you can't do anything about it. Okay? Aging, we all get older, right? I woke up this morning, everything hurt. Okay? As I was moving, things hurt a little bit less. Is that osteoarthritis? Yes. Too many jumps, too many packs, too much craziness. Right? Aging, genetics, some people are just predisposed to it. Obesity, well, if you're putting more weight, the way I like to teach this, right, because remember I'm a physiologist, right? Every pound here, don't judge me, every pound here is 8 pounds on your joints, specifically your knee. So if you're doing math, right, if the patient is 100 pounds overweight, that's a lot of pounds, right, on both knees, okay? So that the obesity can predispose as well. So that's primary. Secondary is basically, the way you think about it is something caused it. Okay? So secondary osteoarthritis, right? Sometimes called post-traumatic osteoarthritis, excuse me, is because something happened. So again, post-traumatic is fractures or osteonecrosis. So when you're going through my course, this course, right? I want you guys to start breaking these words down. Keep it simple. Osteo means bone, right? Necrosis means what? Death. As far as I'm concerned, ortho is like the easiest to learn because they make sense, okay? So is bone death, right? So you think if you have bone death, you can have cartilage destruction? Yeah, they go together. Okay? Then you can have deformity, correct? Okay, so that's the way you think of primary versus secondary, okay? So when we're talking about osteoarthritis, this is the way you're going to see things presented in my course. If you go back, some of you guys, I'm asking you to compromise this, because some people have access to lecture slides from before. I took it upon myself to completely revamp the lecture slides to make it easier for you guys to study and take your notes. Okay? So the way you see it here, you'll see it going forward for every condition. So what are the clinical symptoms? Most commonly is joint pain, stiffness, and deformity, correct? Common locations, again, fingers, knees, hips, and spine. Do you think it's primarily more so for most people in large weight-bearing joints? 100%, we never talked about that, okay? What kind of things in your history will you ask them about, right? I like to think about it in terms of snap, crackle, pop. So when you're doing your OSCE practice and then your Bach OSCE and then your OSCE next semester, you're going to remember, I'm going to ask this patient, do you have any snap, crackle, pop? Do you have any grating, catching, grinding, popping, things like that? Okay, so if you remember snap, crackle, pop, that's what we're talking about here. Okay? And that's due to the osteophytes and the cartilage fragments. Things are floating in there. Okay, things are breaking off, floating in there, things are worn down. Because again, is this progressive and degenerative? Yes. Okay. The answer is yes. So I'm not gonna reread this to you, but do you think that when it comes to osteoarthritis, specifically with end-stage osteoarthritis, that people will come present to you saying that they can't do work, play, or sleep? Yes, those are the three things that will drive people to come see you and start talking about what else can I do. Okay, so you need to know those things, the treatment of it, because you need to know when it's appropriate to refer to someone like me, because we don't do surgery necessarily for people with early arthritis, right? Because we do big surgeries when they have bad arthritis. We replace things completely. Make sense? So work, play, and sleep is the way you should remember that. But again, that's just trying to give you guys some heads up for phase 2. Physical exam-wise, effusion may be present. So what's the difference between effusion and swelling? You spoke first.
The blood versus fluid.
Okay, so an effusion involves a joint. Okay, so an effusion, when you see a knee effusion, it's swelling in the knee joint. Now, can you have superficial swelling around the knee that's not an effusion? Yes. So you need to know the difference. Okay, so when you see the word effusion in a clinical scenario, in the clinical vignette, in my course, or on pants, and they say effusion, you should think inflammation. Okay, does that make sense? Because does osteoarthritis cause inflammation? Yes. But what's the bad thing it can be? Infection. Right? Does infection cause swelling as well? Yes, so we'll get into that. But for now, it's just important to understand that effusion is a specific type of swelling. It's intra-articular or inter-pouch, if you will, depending on the body part, swelling, not just superficial swelling. Make sense? Okay. So it's an indication there's a pathological process occurring. Are we good with that? Okay. Decreased range of motion. Obviously, if you have bone breakdown, cartilage wears down, then bone breaks down. You have deformity, you have angulation. Will they have issues walking? Yes, because they have issues getting to full range of motion. We have something called anatomical range of motion that's necessary to go from a seat into a rising position, for example. Okay? Crepitus. What is crepitus? Grinding. Okay? Grinding. So is crepitus something you're going to feel? Yes. Yes. So understand the difference. Right? You will say that a patient reported they have a grinding sensation, but when you document a physical exam finding, you will say you have crepitus in the range of motion. Make sense? That's the difference. Okay. Joint line tenderness. Okay. Most patients that come in and they say their back hurts, how are they going to say it? It hurts right about here. Same thing with the knee, right? You're going to say, my knee just hurts right about here. And you're going to point to the joint line, and you're going to ask them specifically, do you have joint line tenderness? Okay. Is osteoarthritis intra-articular? So they will have some component of joint line pain. Make sense? Now, if you say, well, point to me with one finger, this is an important concept, where they have pain and they point to the superior portion of the patella, is that necessarily osteoarthritis? No, that's taking you a different direction, correct? So focus in on things like that, okay? So do they have joint line tenderness? Imaging, x-rays, okay? Again, revamp these slides to give you a little bit of mnemonic is coming up. But basically, you think of LOSS, loss, okay? So what is that? Joint space narrowing, okay? Osteophytes, otherwise you might see them documented in a radiographic report as a bone spur, same thing, okay? What's the next one? Sclerosis, right? Sclerosis or subchondral cystic formation. Sclerosis are those thick white lines that indicate that there's intra-articular involvement. Subchondral cysts are literally what it sounds like. They're cysts underneath the cartilage. Are we good with that? And then a little caveat here. Make sure if it's a weight-bearing joint that you get weight-bearing x-rays, okay? If you don't get weight-bearing x-rays on somebody that has advanced osteoarthritis, do you think you're going to see the deformity and the angulation that may be present? No, right? So weight-bearing radiographs are important. Okay? Here it is. I added this slide. So this is how you should remember it. Loss, L-O-S-S. Loss of joint space, so that's that joint space narrowing. Osteophytes, that's those bone spurs. Sclerosis, that's that thickening of the bone that indicates a reaction to an inflammatory versus that grinding and crepitus that we talked about. And then subchondral cystic formation. Do you think once you see subchondral, it's into the bone? Yes. The answer is always yes. Okay, so that's what that picture is showing you there on the right. Okay, that's all those things that we just talked about. Okay, so this is gonna come up a lot, okay? I will go ahead and, this is a good point for me to tell you, I have changed the way the course is. When you read the syllabus, you'll see this. You will not get cumulative tests in my course. You will get tested on specific topics that I teach you, and then we'll move on to the next topic. But something like osteoarthritis, I already mentioned that it can be in hands too, right? And wrists. We do that next block. Do you think this is a concept that will push forward? Yes. So for example, you won't see a spine question on the block 2 test. It used to be that way. Okay. So moving on. So when we talk about specific osteoarthritis, we'll introduce some areas and we'll get more into it. So cervical spine, you also will hear of it called DDD, degenerative disc disease of the spine. Okay, that's the same thing as osteoarthritis, AKA, right? So understand those are the same pathology, the same condition. It can cause neck pain, radiculopathy or myelopathy. What's the difference between radiculopathy and myelopathy? Radiculopathy is based on a nerve root, right? So it's either impingement or encroachment of a nerve root that has peripheral symptomology. Myelopathy is where you have muscle or tissue involvement that's causing symptoms. Does that make sense? Myelo means what? Muscle. So again, when you're reading things in my course, break it down to what the words mean, okay? And pathy, everybody knows what that means. It means disease process, okay? So what's important for all, especially cervical spine osteoarthritis, is that you do a full exam to include a full neurologic exam and gaits. Gait analysis, means you have them walk, correct? You look how they walk. Do they have foot drop? Do they have Trendelenburg gait, which we'll get into? What does their gait look like? It can lead you down to a path where you start thinking about ordering advanced imaging. But what did you order first here? X-rays, right? So this is a lateral radiograph of a C-spine, and it shows you loss, LOSS, right? You have loss of those spaces, okay? You have osteophytes, bone spurs, they're labeled, okay? If you squint really hard and zoom in, you'll see the sclerosis, and you'll obviously see the subchondral cystic changes because there's collapse of the bones themselves, correct? Okay, so you're seeing loss here, okay? So that's consistent, okay? So when we're talking about shoulder osteoarthritis, again, loss is present, okay? When you're talking about loss, okay, you're talking about joint line pain here of the shoulder because you have loss. That loss of joint space, the osteophytes, the sclerosis, and the subchondral cystic changes. Have I beat that to death yet? Don't worry, I'll say it again, at least a million times, okay? But when it comes to shoulder osteoarthritis, right, is that also called glenohumeral joint osteoarthritis? It is, same thing, glenohumeral joint, okay? We'll get into anatomy on Friday. But the glenoid's the cup, and the ball is the humerus, right? The head of the humerus, okay? But when you look here and you see that bone spur is labeled here, okay? That bone spur is labeled there. A lot of times on a radiographic report, because you're going to order x-rays on some old dude like me, right? And it's going to say goat beard formation. That's what that specific spur is. That's called a goat's beard. Everybody knows what a goat's beard is? You've seen a goat's beard? You haven't Googled it? Okay, but it's basically a projection like that, inferiorly, right? That shows up like that. If they have a large osteophyte like that in their shoulder, do you think they're going to have decreased range of motion? Absolutely 100%. So again, I just want you to know these things, not testing them, but in case you guys order an x-ray and you're like, what the hell is a goat's beard? That's what it is, okay? So if you're osteophyte, it's a goat's beard, okay? So do you think if you order an x-ray and you see osteoarthritis, with that you're done? No, you do a physical exam. Not only do they have osteoarthritis, but they now have weakness as well. Does osteoarthritis necessarily cause weakness? No, right? So what maintains the shoulder, that ball in the socket? So your rotator cuff, correct? That's that muscle group, okay? So if you have superior migration like you see in this picture here of the humeral head in relation to the glenoid, you should suspect that the patient may also have a chronic rotator cuff tear. Okay? Everybody good with that? So the restriction of the humeral head in that glenoid socket, in the glenoid cavity, is not being performed by the rotator cuff muscle groups, right? Because they're incompetent. There's a rotator cuff tear. Good to go? Okay? You may see that on pants, guys. Okay?
So,
All right. Sir.
when you use terminology like, in this case, rotator cuff arthropathy,
I try not to get too tricky with it. So arthropathy it's not arthritis, right? So his question is, well, I use terms like arthropathy. Give me an example of what I might ask you.
so like in this picture here with the sliding up of the humeral head, I've just learned that that's termed like rotator cuff arthropathy. So with that, I was asking that, like, would that be like an example of the type of answer choice that you presented?
No. So his question is if I talked about rotator cuff pathology, would I use the term arthropathy as well?
Yes.
Okay, that's what he asked. Okay, good. Not necessarily. I try not to get tricky with it, guys, okay? If I wanted to, I could destroy every single one of you. Okay? And I know this. Okay, so again, I will teach you what I want you to know, and I will test you on what I teach you. Is that good to go? That's too easy. I do that with the residents. You see that in block 4. The residents show up. Fellows, I have some fun with that. But anyways, did I answer your question, sir? Sir?
No questions.
Okay, good. All right, so arthropathy basically just means pathology around a joint. Okay, so technically it's not incorrect. Okay, but it's useless. I want you to know it's a rotator. It's an indication that it could potentially be a rotator cuff tear. That's what I want you to know. Okay? Good to go? Because then might you get an MRI? We get MRIs for soft tissue injuries, right? Is a rotator cuff tear a soft tissue injury? That's what I want you to know. Okay? So, rheumatoid arthritis, so now we're talking about elbow arthritis, right? Elbow arthritis is the worst. Usually with elbow arthritis, you're going to get referred to an upper extremity specialist, even in orthopedics, because there's a lot there, okay? But just so you know, elbow arthritis is something that's very not uncommon in rheumatoid arthritis, okay? So that's when we start talking about rheumatoid versus osteoarthritis. You don't typically see a lot of osteoarthritis, primary osteoarthritis, right? Due to aging, genetics, and obesity, versus traumatic. If you see osteoarthritis in an elbow, you need to ask them about trauma. Okay? So usually they have a history of trauma, unless they have rheumatoid arthritis, which is a systemic disease, correct? Okay. So would you manage a systemic disease different than you would manage just regular old osteoarthritis? Yes, because you give medications that manage the systemic stuff. Okay, make sense? First introduction to that. Okay. So range of motion is critical to quality of life. When you guys go to the drive-thru and you reach for your change, you got to be able to do this, right? When women primarily, but I don't judge, right? But whomever tries to reach back and grab the bra strap and click it, and you got to be able to do that. When you're going to wash the back of your head or the hair that's not existent, I'm just washing my head, right? So you got to be able to do that. So that's that functional range of motion. What did I tell you guys? When somebody has a loss of work, play, or sleep, they'll come see you. That's when they come see you for elbow osteoarthritis. Right? And then you have to figure out, is this RA or is there a history of trauma? Good to go? Okay. Blocks to motion or loose bodies are treated surgically early. Why? Because again, quality of life. They can't do those things I described earlier. It's going to be troubling. If you get an x-ray, because you will, right? You will always get an x-ray, right? And you see little, what I call chiclets floating in that elbow joint, and they're describing grating, grinding, popping and clicking, and you feel crepitus. Do you think that loose body could be the reason that they're having symptoms? So loose body, what is that? So loose body is literally potentially a piece of the cartilage got worn down or got damaged in some way. Now it's floating in the joint. Right? Can you normally see cartilage on an x-ray? No, you can't see soft tissue on an x-ray necessarily, right? Right? For the most part. I will tell you I can. But for the most part. So, well, once the cartilage is broken off, do you think it calcifies? Yes, so then you see it. So you see that chiclet. You'll never forget it now. and then they're describing that they have a block to motion, and when you ask them to extend their elbow, they get to here. Do you think that's troubling for somebody who's trying to get their change to the Whataburger drive-thru? Absolutely. So maybe that's a surgical indication. Okay? I like to keep it lightweight. So osteoarthritis of the hand, you guys already heard this stuff, Hebrides and Bouchards, right? Yes, no? Sort of, maybe? You need to know this, okay? You need to know this because pants, I can almost guarantee you, right? You can hold me to text me the day after, don't text me the day of your test, you're a mess. But the day after your pants and tell me that there was a question on it without test compromise, right? Because I can almost guarantee in some way, shape, or form this concept will be tested. Which one's the dip? Hebrides. Which one's the pip? Bouchards. Right? Are they both present in osteoarthritis of the hand? Potentially, right? And we'll get into that a little bit more. But you need to know which is which, okay? So are those subchondral cystic changes in the joint? Yes, that's what's causing that swelling. The joint has started to deteriorate, the swelling is taken off, and now they could potentially have deformity and angulation as well of those joints. Okay, but again, which one, Hebrides, is the dip or the pip? Dip, distal interphalangeal joint, and the Bouchards is the pip. Okay, that's the proximal interphalangeal joint. Okay, we'll get into anatomy more so on Friday. Right. Osteoarthritis, which is the most common cause of post-traumatic arthritis? Falls. Yeah, falls. Exactly. So someone had a push injury, fall on outstretched hand. You guys will get into that more in block 4. But they may or may not seek treatment, right? Some people don't seek treatment, correct? But now you get an x-ray and it shows some kind of healed fracture. Could they have arthritis now? Yes. So how do we manage that? Do we do surgery for that? Not necessarily, unless, again, work, play, or sleep is significantly involved. But when it comes to post-traumatic arthritis, it's very common in the wrist. Okay, so do you think you need to ask them their history? Do you have any history of any injuries? Okay, whether you sought treatment or not. Okay, that term "fouche," all right, you'll get into it more, but it literally just stands for fall on outstretched hand. So that's just describing how they fell, right? That's very non-specific, correct? But somebody had a fall at some point during a deployment or something like that. They went to Troop Medical Clinic, they're back in the rear, and now they're having wrist pain. You're going to get x-rays, right? And you're going to see degenerative changes. Do you see the changes here? Well, there's an arrow, so hopefully you see the arrow. All right, do you see an area where the bone just looks like it took a little ding, if you will? Okay? So if they point to that specific spot, and that's where they have their pain, then you're correlating that physical exam finding with your radiographic finding. Does that make sense? Okay. A lot of times when you guys order x-rays on patients, do you think the radiologist is going to make comments on things you weren't even looking for? 100%, right? So you'll see the term correlate clinically potentially. That just means the radiologist, I swear to God, they get paid by the word. Right? So they give you all this stuff, and you're like, I didn't even ask about any of that. But did they say anything about the area of pain? Right? Good to go? Okay. Thumb, CMC joint, complementary joint. Okay. Terminology is important. Okay. Carpal means wrist. Metacarpal, hand. Right? So that's that interface there. So CMC joint. So that's the thumb, right? Is that a metacarpal? Yes. So you can see swelling, bony enlargement, and restricted motion. Remember how we talked about with any osteoarthritis, you can have decreased range of motion. So in thumb osteoarthritis, you can see that very, very commonly. Okay. So would you guys agree that what sets us apart from other animals in the animal kingdom is your ability to oppose your thumb with your fingers? Okay. Right. So that ability to do that. So if you have deformity there, they have pain, and they have a little bit of angulation there, do you think they could have a loss of grip strength, right, and pinch strength? Everybody understands the difference between grip and pinch, right? Pinch is this, right? Grip is this. Okay, so you ask a patient, are you having issues turning a doorknob? That's grip, correct? You ask them, are you having trouble doing fine work? Like say they work as a seamstress, right? That's pinch. Understand the difference? Yeah, here's an occupation. did. You guys are gonna start zeroing in on occupations. What is this test here? Oh, my clicker just gave up. Bottom left. That's called a CMC grind test. There's no magic to that. You take the thumb, you secure it in your hand, and you grind on it. Okay, you grind the ball into the cup. If they have pain with that, and you suspect CMC osteoarthritis, and you get an X-ray that shows those changes, what are those changes again? LOSS, right? Then you're thinking about the fact that they could have osteoarthritis of the thumb, otherwise known as CMC osteoarthritis. Osteoarthritis of the hip, very simple. I'm not going to get into this. We get into this next block. Okay, but osteoarthritis of the hip, do you think it's very common in military populations? Yes, in two age groups, two age distributions. Either early, because they had an undeclared, undisclosed condition that was aggravated by running in boots, for example, or older because they're old dudes like me who have been doing crazy things. Okay, but basically with hip osteoarthritis, you have to understand that the one thing I want you to start keying in on now is that when it comes to osteoarthritis of the hip, they'll have decreased internal rotation. Everybody understands what internal rotation is? Do your Daniel son, right? Internal rotation. They're rotating their joint internally. Okay, that's all I'm going to get to for now. And we'll get into hip osteoarthritis. Because you think we're going to talk about hip osteonecrosis as well? Yes, I'll save that for next time. Osteoarthritis of the knee, there's the loss. Genu varum, genu valgum. You guys have a sense of genu varum and genu valgum yet? No? Okay, so genu varum, right, is a certain curvature, and genu valgum is another certain curvature. Okay, and we'll get into that more. And basically, the genu valgum, there's an L in valgum, correct? So the distal extremity goes outwards compared to the proximal extremity, right? So the knee, the tibia, for example, goes outwards compared to the femur, and that's valgum. That's valgum deformity. If it goes in the opposite direction, meaning that the tibia goes inward compared to the femur, then that's varum deformity. We good? Okay. Now that right-hand picture there, is that varum or valgum? That's varum, right? Thou shalt not bears. That's a rule in orthopedics. Well, which compartment do you think gets the most involvement with osteoarthritis of the knee? The medial compartment. And that's what that picture is showing you there. Everybody agrees that as you go, I'm sorry, my clicker stopped working. As you go more so to the arrows on the right, that's a medial aspect of the knee, correct? So that's a medial compartment, okay? So that's more common in osteoarthritis of the knee, okay? So when we talk about advanced imaging, again, I'm now going to give you a slide that shows one slide of one image on MRI and say, what is this? Okay, that's not fair, okay? And plus, this isn't that course, okay? But you may get something in the actual vignette that tells you a finding on an MRI. That's fair game. But you think I'm going to quiz you on how to interpret an MRI? No, I would have to give you like 300 image, slides, right, with 300 slices of an MRI to be fair. And that's not fair if I just give you one slice, okay? But I just do want you to understand that on MRI, if you look at this picture here on the left, right, and you see the arrows and you see the pathology there, some of you see it, right? But then we get in and we look at the joint, how? Through arthroscopy. So we stick an instrument into the joint and we see these changes on arthroscopy because you're looking at it, right? You're staring at that joint surface. Then you go back to your imaging and say, okay, they correlate. Does that make sense? So what do I mean by that? An MRI is a snapshot in time. And sometimes when we get in there and we look at it under arthroscopy, it's more significant pathology. Make sense? So again, an MRI is not 100%, but it's a good start, especially for surgical planning. Okay? So treatment-wise, we'll get into this. Again, we talked about this. But the bottom one, I want you to understand. What's the difference between an arthroplasty and an arthrodesis? I alluded to this earlier. So an I'll tell you. So joint arthroplasty, right, is when you replace the joint. You take something that was not there. So you see those pictures on the bottom there? That's not what your native hip looks like, correct? That's not what your native knee looks like. So you take what wasn't there, put it in there to give them a new joint. Okay, very commonly again, hips, knees. Okay? And orthodesis is where you fuse those joints to stop that motion. If you think if somebody has advanced osteoarthritis of their ankle, then it may hurt when they get put in certain positions. It does. So you will fuse those joints instead of replacing them. That's an orthodesis, okay? To stop that pain. You think if you stop pain in one area, that it can cause pain to pop up in other areas if you do an orthodesis? Yes. But I use ankle for a good example because we don't do a lot of ankle arthroplasty, especially in the military, because that usually means you're done, right? You can't have a fake ankle if you run out there. Okay. So people remain on active duty with replaced joints, as for example, hips and knees, all the time. It depends on your MLS, but it's more common. But ankles, pretty much done deal. So sometimes orthodesis, again, you just try to give them a better quality of life, allow them to keep pushing. Sorry. It will. So that's the problem with orthodesis. So he said if you fuse that ankle joint, won't that cause a permanent decreased range of motion? It will. So if you don't have motion at that ankle joint anymore, where they fused it, you think you might have knee pain? Yes, because it translates those forces somewhere else, correct? You think they might have foot pain? Yeah, so orthodesis is not a good answer. Did I answer your question, sir? No, so it's not a good answer. For arthroplasty, I just want you to know the difference. If you see someone come for a post-op, after surgery for a post-op follow-up with you, right, and they say, I had a total joint arthroplasty of my hip. Okay, you know what that is, right? They have a new hip. Brand new hip. It's an awesome surgery. So. But do we do arthroplasties more so with young people or old people? Old, because they have degenerative osteoarthritis. Okay? I'm not going to get into the adverse outcomes again. You guys understand that. We talked about that. But we start talking about. Yeah.
Sorry, for the joint arthroplasty, do they have to get replaced every now and then, like every 10 years? Or
So her question was, if you have a total joint, I think his question was, if you have a total joint arthroplasty, do you have to sometimes do maintenance on it? You have to go in there and like change things out. Some of the newer stuff is better, right? Longevity is better. That gets into a whole discussion that I promise you I wouldn't go down, right? I worked total joints for 4 years. I love it. Okay, but when you replace a joint, you tell the patient your life is not changed. You cannot do high impact stuff. Because if you do high impact stuff, do you think you'll wear down that joint faster? Yes. Okay. So I don't want to go down the path of like specific alloys and things like that from the instrumentation that we use. That's instrumentation, right? Okay, good. So, because that's a whole separate area, but potentially yes. So, do we want to do total joint arthroplasties in young active people? No, because there's incidence of repeat surgical procedure based on their wear down with prosthetics, instrumentation, right, is higher. Make sense? But sometimes you have to, and we'll get into that when we talk about osteonecrosis, okay? Post-op complications. What is a post-op complication? Well, that's anything that happens after surgery. The patient presents to you and says they have fever of unknown origin, and they had surgery a week before. Are you thinking infection? Always. You will learn my paranoia. You will share in it with me, okay? When I see pain and I see swelling, all right, I'm always thinking infection, okay? We'll get into that when we talk about pathology, okay? So, referral decisions, I mean, I talked to you about that already, right? Workplace sleep, loss of range of motion, loss of normal function, okay? That's all I got for you guys today. I won't read this to you again, but these are the topics we discussed. Just so you guys know, the next time we come in tomorrow, I do a quick review of high-miss topics or high-yield topics. I answer questions again, and we can roll right into the next set of subjects, okay? Thank you for your attention. Have a good rest of your day.
Thanks, sir.